This is a CT without IV contrast administration on a 74-year-old male patient who presented with acute confusion. So let's start by discussing the findings. The abnormality is obviously seen in the left temporal lobe. The most involved area of the left temporal lobe is the medial aspect of the temporal lobe, where we expect the limbic system to be living. Now, the left insula is also abnormal, and the entire region shows an ill-defined hypodensity, where you might wonder about ill-definition of the gray-white matter distinction. There's also some mass effect. If you compare the left temporal lobe to the other side, you could see some sulci here which are not clearly identified on the abnormal side. Now, is this the only abnormality? Looking carefully, you might wonder if there is inferior frontal lobe involvement as well. To better appreciate this, let's go to what we call a stroke window, where we change the contrast to make everything dark. With that, you could appreciate the abnormality in a better way. You could also see that there is involvement of the inferior frontal lobe on the left side. You might wonder about involvement of the cingulate gyrus, which is the gyrus that arches on top of the corpus callosum. Not only that, there is a very subtle abnormality on the other side. So there is involvement of the medial aspect of the right temporal lobe as well. Despite of all of this involved area, you still have a left lentiform nucleus, a left caudate nucleus, and a thalamus which are intact. So given the appearance, what are the differential diagnostic possibilities that you should think about if you're on call? Although this case was sent to the on-call resident with a question of rule out stroke, this is not the first thing you should think about seeing the appearance. Given that it's multifocal, bilateral, and in particular it involves the medial aspect of the temporal lobes, you have to think about an infection. And a famous infection that looks like this is herpes simplex encephalitis. Now, infarction, which is a very common clinical question, does not appear like this. For infarction to involve multiple areas, that would be less common and usually is a result of a cardioembolic stroke or vasculitis. The location of the medial temporal lobes bilaterally is unusual, and the classic differentiating point between herpes encephalitis and infarction is that herpes classically spares the basal ganglia. Could this be a neoplasm? Now, the acute presentation would argue against a neoplastic process, and the multifocality makes neoplasm less likely. However, there are rare cases that are described of bilateral primary brain neoplastic involvement in the context of something known as gliomatosis cerebri, which is very rare as well. Since herpes encephalitis was suspected by the CT scan, an MRI was performed. I'll give you a chance to look at the various MRI sequences. Now let's go over the MRI findings. Starting with the T1 weighted acquisition, it is not that easy to appreciate the abnormality. However, we know what we saw on the CT scan, so let's see if we could see subtle findings. On T1, you could at least appreciate that there is asymmetry in the size of the sulci in the involved left temporal lobe compared with the less involved right temporal lobe. You might wonder if there is an asymmetric appearance of the insular ribbon on the left side compared to the right. Otherwise, it's very difficult to see other abnormalities. Now to the T2 weighted image. There are some patchy changes within the centrum semiovale and corona radiata consistent with microangiopathic chronic findings. However, it's a little bit more clear that you have high signal intensity in the cortical and subcortical medial left temporal lobe, a lesser extent of the involvement of the medial right temporal lobe. This is a nice slice that shows you the cortex that's bright, especially compared to more normal cortex on the other side. As you go higher up, you see that the insula on the left side is abnormal. The right-sided insula is relatively normal. You might wonder about some signal changes here. However, the anterior part of the insula is okay. This is a nice slice as well that shows you asymmetry in the appearance of the cortex and subcortical white matter in the inferior frontal lobes. It's more pronounced on the left side, of course. Now on FLAIR, where CSF is dark, it's much easier to appreciate the signal intensity changes in the insular cortex. Changes also in the medial aspect of both temporal lobes in an asymmetric fashion, being more pronounced on the left. Now the findings are most obvious on the diffusion weighted image. You already start seeing these cortical signal intensity changes that are bright on diffusion. Notice that involves both inferior frontal lobes in an asymmetric fashion being more pronounced on the left side, asymmetric involvement of the insular ribbon also more pronounced on the left side, and the same thing is happening in the mesial aspect of both temporal lobes. The involvement is, as you see, mainly cortical with some subcortical involvement. To decide whether the changes that we saw on T2, flare, and on diffusion are related to cytotoxic or vasogenic edema, let's correlate what we saw with the ADC map. On the ADC map, you could see that the areas of involvement are dark. As you go to the more involved region, the darkness is more appreciated here in the insular ribbon as well as in the medial temporal lobes. And this is a hint of the cytotoxic nature of the edema involving the abnormal regions. This is the susceptibility weighted image. A quick look at it demonstrates no obvious abnormalities apart from a few dark spots here and there, which may be related to microangiopathy. However, the region of involvement does not show any obvious concentration of artifacts in the mesial temporal lobes or in the inferior frontal lobes or even in the insula. And the reason we're looking at that, you want to make sure that the areas of involvement by the infection are not associated with hemorrhagic components, which could happen. Finally, to complete the case, this is a T1 sequence after administration of intravenous contrast to see if we have any abnormal enhancement in general. Since this is an infection, you need to check enhancement of the meninges, but also these infections may be associated with various patterns of enhancement in the involved regions, which we don't see here, so there is no abnormal enhancement in this case. Given that we saw the abnormalities in a very clear way on MRI, what is the differential diagnostic list now? Infection from herpes encephalitis remains the major consideration given the appearance and the patient's presentation. Another entity that could mimic herpes encephalitis is autoimmune encephalitis, also known as limbic encephalitis or paraneoplastic encephalitis. The name is not that accurate since limbic encephalitis actually is a term which may also be used with other inflammatory conditions that involve the limbic system, so that could be confusing. Add to that this autoimmune process is not only related to paraneoplastic syndrome, it may be associated with non-neoplastic abnormalities. With autoimmune encephalitis, the condition is related to release of autoantibodies that target the limbic system and may target other areas within the brain. Now, the clinical presentation of such an entity is usually subacute or chronic. The clinical presentation may overlap with infection. Some patients may rarely even have fever. However, these patients typically present with manifestations that are related to memory disorders or due to a change in the psychiatric behavior of the patient. So a gradual onset with memory or psychiatric symptoms is typical of this entity. Now, when it comes to imaging, things that could help you differentiating this entity from an infection is that autoimmune encephalitis is classically not associated with mass effect. You probably wouldn't see it on CT because it's subtle and it would appear only on an MRI. There is no associated hemorrhage or restricted diffusion with this entity, so all these things would make you shy away from autoimmune encephalitis if you see them. Another good point to keep an eye on is that autoimmune encephalitis classically involves the most medial aspect of the temporal lobe. So if you have lateral extension of the findings within the temporal lobe, such as what we saw here on the left side, this would make autoimmune encephalitis a less likely possibility. Now, another entity that could look like this is a patient who has seizures. Specifically, we're talking about status epilepticus, which is seizure that is continuous or repetitive without response to treatment. This entity as well is usually normal on a CT scan. You'd only see the cortical and subcortical changes in the medial aspect of the temporal lobes on an MRI. Occasionally, the entity may lead to some mass effect and variable degrees of enhancement, which might confuse you with other entities if you don't know the clinical presentation. An infarction in the MCA territory is something you might think of. But notice that the clinical presentation of herpes encephalitis is really different than that of an infarct, so that makes it much easier. If you're in a vacuum and don't know the patient's presentation, that might confuse you. However, the bilaterality of the abnormality and the classic location should make you think about herpes encephalitis first. This entity, which is acute hepatic encephalopathy, is not a classic entity that's mentioned in this context. Books don't tell you that. However, I could see how this could be confusing to people, and that's why I included it here. Acute hepatic encephalopathy leads to cortical and subcortical changes that could involve many parts of the brain. The most typical and the most common involvement is that of bilateral insula and cingulate gyrus. Because of this insular involvement, the appearance on MRI may be confusing for the above-mentioned entities, so keep that in mind. Something that's classic about acute hepatic encephalopathy is that it relatively spares the area surrounding the central fissure and the occipital lobe. In severe cases, there might be diffuse involvement, but these areas would be relatively spared. The final diagnosis in this case was that of herpes encephalitis. Let's talk a little bit about this entity. Herpes virus accesses the body through the nasopharynx and remains dormant within the trigeminal nerve ganglia. The infection is classically related to type 1 herpes virus, and that's about 95% of the cases. For some reason, the virus reactivates. This could be seen at any age and could be seen in any immune group. So you could see it in immune competent and immune compromised. And if this happens, it has a very bad prognosis. About 2/3 of the patients die. A very important point here is that the earlier the diagnosis, the better the prognosis. When this entity is diagnosed early, antiviral medications are started earlier, and this could improve the prognosis. And this is important for us as imagers. CT is typically normal initially in the early course of the disease, but if the disease is severe or it has been prolonged, you might see changes on a CT scan, and that's not a good sign. It could be complicated by bleeding, and hence you might see hyperintensities on T1. You could see bleeding-related changes on T2 or susceptibility-weighted imaging. Enhancement is usually not present in this entity. However, rarely you might have various forms of enhancement such as meningeal or gyriform patterns. So what are the highlights of this case? A very simple and practical point that I want to highlight here is when you look at CT on call, you have to change to a very dark contrasty window. And that window is about 40 for width and 40 for level. Without doing that, you might miss strokes and other subtle abnormalities, and this was a good example. After changing to this darker window, you could see the changes on the CT in both instead of in one temporal lobe. Another thing to highlight is to know this classic differential diagnostic list. So when you have bilateral medial temporal lobe changes, the classic differential entities would be herpes simplex encephalitis, limbic encephalitis, or better called autoimmune encephalitis, and status epilepticus. How to differentiate between herpes encephalitis and autoimmune encephalitis? The clinical presentation helps. With herpes encephalitis, it's typically more acute versus autoimmune encephalitis where the presentation is subacute or chronic. As we mentioned, overlap does exist. If you see changes on a CT scan, that makes autoimmune encephalitis less likely, so probably you're looking at a later stage or a severe stage of herpes encephalitis, since it would be very difficult to see autoimmune encephalitis on CT, especially that this is an entity that's not associated with mass effect. The location within the temporal lobe. Both entities involve the temporal lobes in a bilateral asymmetric fashion. They're both cortical and subcortical. However, if you see lateral extension in the temporal lobes or involvement of the insula, you'd have to favor herpes simplex encephalitis. Mass effect is typically absent in autoimmune encephalitis and is seen in herpes simplex encephalitis. Bleeding is absent in autoimmune encephalitis as well. And on diffusion and ADC, you'll see restriction with herpes simplex encephalitis, which is usually absent with autoimmune encephalitis. Now, to differentiate herpes simplex from infarction, clinically it's usually an easy thing to do. But the reason I bring this up is that sometimes, as I mentioned before, we might not be privileged to all the clinical information on call. And if you don't know the presentation, you might confuse both entities. So ask for the clinical presentation. If it's unilateral, it may become more difficult, but when it's bilateral medial temporal lobe, that makes an infarct very unlikely. Involvement of the basal ganglia is atypical for herpes simplex encephalitis. It's very typical for MCA infarctions. And that concludes this case of herpes encephalitis. Here's a food for thought question before we leave this case. We talked about the imaging appearance of acute hepatic encephalopathy. But what is the classic brain MRI appearance of chronic hepatic encephalopathy? That's something you could read about and answer in the discussion part of the case.